With all the steroids, SARMs, peptides, growth factors, metabolic modulators, and fat burners out there today, one still remains king. Whether you are trying to gain muscle, get stronger and faster, lose fat, improve body composition, increase confidence, or become a mutilated porn star, Test is best. You know that the natural ways of increasing testosterone can only get you so far, and want to learn about the alternative ways of increasing testosterone. Join me in this video to cover all things exogenous testosterone. So, let's go. Okay, let's start off with a bit of a warning. I am not a doctor, and if you are going to take exogenous testosterone, make sure you do so under the guidance of a medical doctor. Ideally, one that is specialized in this field. Do not attempt any of the methods mentioned in this video if you are a woman, unless you want to become a man, or if it is medically needed. And if so, it would be at very low doses and under the supervision of a medical doctor. Always run blood work before starting. Maybe in a future video, we can go over how to understand blood work and what to test for. Be ready to lose your fertility, at least temporarily. But if everything is done correctly and extra precautions are taken, this issue can be mitigated or eliminated entirely. Before proceeding, make sure you are of age, meaning you are at the very least fully developed physically and sexually. Have a valid reason as to why you are messing with steroids. Hopefully, not just to look good. There are several natural ways, but also pharmaceutical ways to boost your own endogenous production that are worth understanding and potentially attempting before going down this route. Now that we got the warnings out of the way, let's begin. Okay, so typically today, whenever testosterone is administered to the human body, it is in an esterified form. So basically what this means is that the testosterone is chemically modified to have an ester attached to it. And the whole point of this is to prolong its release into the body, which in turn allows for lesser frequent injections. So the way this happens is basically the body cleaves off the ester and then the testosterone is free to attach to the androgenic receptor. The process where the body cleaves off the ester is called hydrolysis, and it typically happens in the blood and liver. There are different esters which determine how long the testosterone lasts in the body. So typically the heavier the ester, the longer it lasts. And usually the heavier the ester, the less testosterone is available when you're comparing milligram per milligram. So if you're comparing testosterone cypionate to testosterone enanthate, if the cypionate has a heavier ester, that means that milligram for milligram, there is more testosterone in the enanthate. So it's also worth noting that the ester determines how lipophilic the testosterone is. So typically, testosterone, when it is injected, it can be injected subcutaneously or intramuscularly, meaning in the fatty tissue or directly within the muscle. The lipophilicity of the ester means how quickly it breaks down in the oil. Worth noting that testosterone, when it's injected, both intramuscularly and subcutaneously, it is in an oil form, an oil base typically. Now, what the ester dictates is how long the testosterone lasts within the oil before it is released into the plasma. This is called the lipophilicity of the ester. A point worth mentioning is it's not just the ester alone that determines how long it takes for the testosterone to be released into the system, but also the carrier oil. There are castor oils, MCT oils, sesame oils, grapeseed oils, etc. So the carrier oil also plays a role in how long the testosterone takes to be released into the system. Okay, so now that we got the esters out of the way, let's start to understand what types of testosterone there are available to us when it comes to administering extra or exogenous testosterone to the human body. Let's start off with testosterone suspension, which basically is an unesterified testosterone. So it has the shortest half-life. Once it is injected, it is released into the system immediately. It will last in the system for just a few hours. And it has been around since the 1940s. So shortly after testosterone was isolated or synthesized, I think it's 1937 when that happened. So of course, testosterone suspension is not that commonly used today because it requires extra frequent injections and they're also pretty painful too. It can be used in hospital settings, very unique situations, apparently when an immediate androgenic effect is required. And it is sometimes used in bodybuilding or athletic circuits. One way it is used is as a pre-workout. For example, whenever a powerlifter needs a very controlled boost in testosterone suspension, suspension can be utilized in that scenario as a pre-workout or pre-competition. The claims are that it has less water retention too, so this can be a benefit for bodybuilding purposes potentially. And it can be used to also potentially trick the PED tests that are run on athletes. The reason why is because it's in the system for a very short period of time. And once the testing is done, it can potentially be already cleared from the system. In the research realm, it is still utilized occasionally when comparing an esterified testosterone to a free testosterone or to an unesterified testosterone, which is testosterone suspension. Okay, so the two most popular forms of esterified testosterone that are used today are testosterone cypionate and testosterone enanthate. These were developed in the 1940s, 1950s, and the purpose behind their development was to have less frequent injections, meaning every injection lasts longer in the body. The release is unlike suspension, which is immediately delivered. The ester is controlling the release, and the protocol requires less injections to keep the same testosterone levels within the body. These two esters are very, very similar. They have a very similar half-life too. The testosterone enanthate has a 4.5-day half-life and cypionate has a 5-day half-life. I have seen multiple protocols when injecting testosterone enanthate or cypionate. You have people who are injecting it once a week at the very least, and then you can do it twice a week, 3 times a week, every other day, or every day as well. The advantages of different protocols is not the purpose of this video. We just want to cover all the different types of testosterone available. Okay, when it comes to the actual testosterone available, if we were to take 100 milligrams of each enanthate and cypionate, the enanthate will have 70 milligrams of testosterone in that 100 milligrams, and the cypionate will have 69 milligrams. So as you can see, in all senses, they are very, very similar. Geographically, enanthate is more common in Europe and Asia, while cypionate tends to be more common in the US and Canada. All right, moving on. Testosterone propionate and testosterone phenylpropionate. Also two very similar esters. Testosterone propionate was the first esterified testosterone to be released, which happened back in 1937. Basically, testosterone propionate is the shortest acting ester when it comes to esterified testosterone. It kind of has a slightly faster release than suspension, and its half-life is typically 2 days or 48 hours. Protocols, ideally, you want to inject every other day at the very least, or every day. This ester is actually starting to become more and more popular because it has the potential of mimicking the natural circadian or diurnal rhythm of testosterone production, where you have a peak once a day and a trough once a day too. If you were to inject enanthate once a week, you would have your peak coming in on one of the days of that week and the trough coming in on another day. So it's not a daily pulsation of peaking and troughing of testosterone. In bodybuilding, propionate seems to be used at the beginning of a cycle. Traditionally, like everything is constantly changing, but traditionally you have it being used at the beginning of a cycle to sort of elevate levels much faster than slower acting esters, because slower acting esters take time to build in the system, where propionate is much faster overall. It's also used pre-competition when the bodybuilding coaches, for example, want to have the ability to pull out testosterone at any point. If they were utilizing enanthate, for example, and they wanted to pull out the testosterone from the regimen of the athlete, the issue would be that the testosterone enanthate would take a long time to clear the body and it will prolong the effects to be shown. So propionate, as soon as it's pulled out, you can start to see the effects of that withdrawal quite instantly. A subjective report is that it has less water retention and it is known to have slightly more PIP or post-injection pain. This is due to it containing higher benzyl alcohol. All right, moving along to longer lasting esters. One of them is much longer actually. So we have testosterone decanoate and testosterone undecanate. Starting off with the decanate, the half-life of this ester is 7 to 10 days. As a standalone, it is rarely used. We find it in a blended version of testosterone called Sustanon, which we're going to cover shortly. And due to its lengthy half-life, it can be detected in the system for 3 to 4 weeks after the last injection. Testosterone undecanate is used as a standalone, typically for testosterone replacement therapy or TRT. I really don't like the way this protocol is implemented, to be honest with you, because it enters the system way too slowly and exits the system way too slowly as well. So if you were to take these two different points in the timeline, the testosterone levels are going to be drastically different. Imagine the half-life is 20 to 34 days on testosterone undecanate. Its brand names are typically Nebido or Aveed, and it is typically dosed every 10 to 14 weeks. There is also an oral version of Undecanoate, which we'll cover soon, and it seems to be favored in Europe and Asia for TRT purposes. After the last injection, the testosterone can be detected for up to 6 months post-injection. A typical dose is about 1,000 milligrams every 10 to 14 weeks. And although this sounds like a huge dose, what really happens is about 70 milligrams or so get released into the system of testosterone per week, which is quite a low dose actually, on today's TRT standards. On screen, you can see a bit of a difference between testosterone decanoate and testosterone undecanoate. Okay, so another version of testosterone is Sustanon. So this is basically a blend of 4 different esters. As we previously mentioned, Decanoate is used as the longest lasting ester of the 4. You have testosterone propionate as the fastest acting ester. Then you have phenylpropionate, which is slightly slower release. And then you have isocaproate. I've only ever seen it in Sustanon. And on screen, you can see the half-lives of each of the esters within Sustanon. The effective half-life of Sustanon as a whole is 7 to 10 days due to the decanoate ester. This version of testosterone was designed to have less frequent injections and have the benefits of faster acting esters, and it was developed by Organon over in the Netherlands. And it is still pretty popular in Europe and parts of Asia. The reality of Sustanon, although on paper it sounds like a wonder version of testosterone, it still has peaks and troughs. One of the biggest disadvantages of Sustanon is that it is less predictable than a single ester testosterone version like Cypionate, and its availability is pretty limited, especially in the US. Okay, so now to one of my favorite versions of testosterone, especially for TRT purposes. It is testosterone cream or compounded cream. First of all, this is not to be confused with testosterone gel, which is an older technology to testosterone cream. Now, testosterone cream is basically, as it sounds, it is cream that contains testosterone, which is completely unesterified. It started to be manufactured in around the 90s or 2000s, shortly after gel was starting to hit the markets. However, I would say it increased dramatically in popularity in about 2010 onwards. Basically, it can be applied to any area of the body. So it can be applied to the upper arms, the abdomen, the inner thighs, what have you. But one of the most popular ways that it is being applied right now is on the scrotal skin. The reason for this is that there is an extremely high vasculature system in this skin. Also, the skin is very thin, so a lot more is absorbed when applied scrotally. And one of the best advantages of it being applied scrotally is that the scrotal skin and the surrounding areas have the highest concentration of 5-alpha reductase, meaning when you are utilizing testosterone cream and comparing it to utilizing another injectable esterified testosterone, the cream application on the scrotal skin will result in higher DHT conversions, which many individuals look for. The advantages of higher DHT, aside from the DHT itself, is that estrogen can potentially be controlled a bit better. So typically the testosterone cream comes in a Topical container. I actually have one, let me go get it. So yeah, so it looks something like this. You simply take the top off, if you can see this. Basically, you turn the bottom and you get a click every time you turn. Each click is a dose. So depending on your dosage protocol, you have X amount of clicks to apply per Y amount of time. The most common versions are 25 milligrams of testosterone per click or 50 milligrams. So yeah, back to the difference between the cream applied anywhere on the body versus on the scrotal skin. In the scrotal skin, it has been found that there is about 17 to 23% absorption. So if you're applying one click of 50 milligrams, it's about 10 milligrams that's being absorbed when applied scrotally. And applying it scrotally results in about 3 to 5 times more absorption than applying it to any other area on the body. Also, the DHT increase when applied scrotally is about 2 to 5 times higher than applying it in any other skin area on the body. Now, of course, this version of testosterone comes with a lot of advantages. The main one being you don't need to worry about any syringes or needles. You can apply it daily or twice daily, so you're going to have much more stable levels. The delivery system seems to have a very stable release as well. Although the testosterone is unesterified, what happens is, at least this is my theory, that once it is applied to the skin kind of is a reservoir where the release is gradual. It's a very easy delivery system to fine-tune. So as soon as you make an adjustment, you could pretty much feel the differences right away. However, it does have a few disadvantages. So the absorption rate varies from person to person, depends which part of the body you're applying it to, etc. The biggest risk, in my opinion, is the risk of transference. There is a residue of the cream left on the skin for about an hour or two, and within that time frame, if it is contacted with anyone else, it can potentially risk transferring. When it is applied scrotally, there is that advantage of less transfer risk. Another version of testosterone which has kind of increased in popularity recently, or at least I would say it's trending more so than being actually popular, is oral testosterone. So the main form of oral testosterone is literally an esterified version, Undecanoate, which we previously mentioned. Now, the Undecanoate in the oral form is not the same half-life. It's pretty much released instantaneously. Brand names for oral testosterone Undecanoate are Andriol, Jatenzo, and Tlando, if I'm pronouncing them correctly. And the way this oral form of testosterone works is it's absorbed through the lymphatic system. So typically, which is an issue in my opinion, it needs to be ingested with a fat source every time. And keep in mind that the half-life is very, very, very short, so it needs to be ingested twice a day or so. There is an older version of oral testosterone called methyl testosterone, which, as its name implies, it is a methylated version, and basically it is highly hepotoxic or toxic to the liver. So it is rarely used anymore today. And it is actually banned in certain regions. Here we're getting into versions of testosterone which are very niche, not that popular, and not that effective either. So we have buccal testosterone or sublingual testosterone. Brand names are Striant. This is basically applied to the gums and it is absorbed gradually through the oral mucosa, and therefore it bypasses the liver. Of course, it avoids the need for injections, which many men tend to fear, but I don't really see this as being a very, very popular option, to be honest. More or less common forms of testosterone are testosterone gel, which is the predecessor to testosterone cream. The main issue with the gel was that it requires a huge surface layer of the body to get absorbed due to its weak potency, and of course that results in very sporadic dosages and also high risk of transfer. Less DHT boost as well, and very cumbersome to maintain the protocol. There are also testosterone pellets, which are injected into the body and they have a very long release into the system. So typically they're injected into the subcutaneous fat of the body. Testopel is a very well-known brand for this methodology. And basically the pellets, once they are injected into the body, release testosterone for about 3 to 6 months after their implantation. Each pellet is about 75 milligrams of testosterone, and it's called crystalline testosterone. So it's an unesterified but crystallized version of testosterone. So it is slowly released, although it is not in the form of an esterified testosterone. So typically, being each pellet is 75 milligrams, you will have doctors implanting multiple pellets depending on what dosage or what level of testosterone they are aiming for. Usually, a typical protocol is about 6 to 12 pellets implanted at once, which equates to about 450 to 900 milligrams of testosterone. And the pellets, like we said, would be releasing the testosterone for about 3 to 6 months. So that means an individual undergoing this protocol will need to implant pellets 2 to 4 times per year. Now, the kinetics of how the testosterone is released, typically what we see is a gradual increase in the first few weeks, the first 1 to 3 weeks, and then a slow but relatively flat release for the 3 to 6 months following. Of course, a huge problem with this protocol is if you need to make adjustments, you're going to have to wait a long time to do so. The advantages are high adherence, so the individual just needs to undergo the implantation and that's it, and there's no risk of transference either. It also seems to be relatively steady plasma levels. Another not so common version of testosterone, which is going to skimp over, is intranasal testosterone. So this is a newer, less common version. One of the main brands is called Natesto, and it is basically a gel that is applied into the nostrils with a metered pump. It's absorbed rapidly through the nasal mucosa, which has a rich blood supply. In turn, it avoids the first pass of the liver, and it needs to be dosed pretty frequently because it has a very, very short half-life. Typical dose is 5.5 milligrams per nostril at once, so that's 11 milligrams total, 3 times per day. It peaks in about 40 minutes and declines rapidly, and baseline is reached within 4 to 6 hours after administration. The half-life has been reported to be 1 to 2 hours. This is only found in certain countries like the US and Canada, and is limited worldwide. Worth mentioning quickly testosterone patches, which is another transdermal TRT protocol or option, and it's been used since the 1990s with brand names like AndroGel. Basically, each patch is applied daily and it's about 2 to 6 milligrams of testosterone, and it releases the testosterone throughout the day. Typically, the patch though is applied at nighttime. It's applied at nighttime because it can be more discreet. There have been adhesive issues mentioned, and the dosage is very, very limited on these patches. They also seem quite costly. So to conclude, testosterone is widely utilized today, especially for TRT and HRT purposes. It is still utilized widely as a PED or performance enhancing drug as well. Typically, whenever an anabolic cycle is administered, testosterone is usually the backbone of this cycle. The reason for this is that anabolic androgenic steroids, although they're not bioidentical, they still shut down the endogenous production of testosterone. And in order for athletes to still feel good, at the very least, they need to administer testosterone exogenously along with the other anabolic steroids. Despite all the different versions of testosterone we mentioned today, testosterone Enanthate and Cypionate are still the golden standard, whether it's for TRT or PED usage. And like we said, Propionate is starting to creep up in popularity as well. But what is the reason why Cypionate and Enanthate dominate? So firstly, they are reliable. They have good pharmacokinetics and they have been studied for years. They are cheap, much cheaper than gels, creams, nasal sprays, etc. The dosage is very flexible. You can change the frequency of administration, the dosage amounts, what have you, and they are widely available. Now keep in mind that Enanthate and Cypionate were put to the market in the 1950s. Not to mention that Propionate is from 1937. And as you can see, nothing since then has ever dethroned them. There has been advancement for sure in the technology around testosterone or the science around testosterone. However, all of the newer methodologies come with some form of issue, as we hopefully covered earlier on. That being said, in my opinion, the most prominent advancement in testosterone science is that of compounded cream, which was invented in the 2000s, but the scrotal administration of the cream picked up in 2010 onwards. And the beauty of this methodology is that firstly, it's bioidentical. There are no esters. It's pure testosterone being applied to the body. Secondly, it's being applied to an area where endogenous testosterone is fundamentally created. So this is why you're getting that higher conversion to DHT due to the 5-alpha reductase enzymes present in the area. And due to its frequent administration protocols, it can very closely mimic the natural production of testosterone. So for TRT purposes, I think this is gold. Okay, so today we spoke about the exogenous administration of testosterone. However, you need to keep in mind that there are many ways you can boost your endogenous testosterone production, whether it be a natural methodology or even a pharmaceutical one, such as enclomiphene. Hopefully, this was a bit of an introduction to exogenous testosterone. Please let me know if you have any questions so that I can prepare the next videos going forward according to what you guys want to see most. Don't forget to like and subscribe. I'll actually wait for you to do so. I hope you enjoyed this video, and as always, onwards and upwards.